of APPS. This grand round aims to provide a platform for exchanging knowledge and experience in pediatric pulmonology among Asian countries, and hopefully we can establish a strong collaborations and cooperations to make a progress in the field of pediatric pulmonology in the future. I would like to thank Dr. Alvin Chang, the president of Singapore Pediatric Society, to co-host and support this event. Special thanks must go to Dr. Mahesh Babu, who voluntarily organized this grand round. He has spent great effort and lengthy hours to prepare this grand round to give most educational benefits to our audience. Dr. Mahesh Babu is a senior consultant and head of Pediatric Respiratory and Sleep Division, Department of Pediatrics, National University Hospital, Singapore. So please welcome Dr. Mahesh Babu.
Thank you so much, Dr. Arunwan. Mahesh here. Thank you so much for that kind introduction and the welcome. It gives us great pleasure to organize this case presentation, which is now becoming a monthly event in the calendar of APPS. And this month, the case presentation is coming from Singapore. Before I introduce my panelists and the presenter, I would like to have a couple of minutes for just giving you some housekeeping on webinar. So you will all be able to hear and see us on the webinar. We unfortunately cannot see you or hear you. However, we have quite a few ways in which you can interact with us, and you can also interact with each other. Please use the chat button to ask questions to the panelists. Don't use the Q&A, use the chat button to ask questions, because that is where we will be looking for. Use the Q&A button to talk amongst yourselves and your colleagues. You can chat as much as you want on the Q&A. Also, we have a few polling questions, and you can interact with the audience and also direct the way in which this discussion is going to go based on your polling. So please use the polling feature very well. The chat questions will be answered by the panelists at the end. My colleague, Dr. Michael Lim, who is also a senior consultant in the department, has kindly consented to help us collate all the chat questions, and then we can present it to the panelists at the end. If there are some questions which not unfortunately address, we will address it in the video which will be recorded at the end. Okay, with that, those few words, I would like to introduce my panelists. My first panelist is Professor Sushil Kabra. He is a senior consultant and professor of pediatrics at the All India Institute of Medical Sciences in Delhi. He's also the editor-in-chief of the Indian Journal of Pediatrics. He is a fantastic clinician. He is single-handedly driven the Sea of Care, started and driven Sea of Care in India, which is now very, very important. Apart from that, his interests are very varied in respiratory, pediatric respiratory field. He's got great research interests in cystic fibrosis, asthma, TB, etc. And he has many publications to his name. Welcome, Dr. Kabra. Thank you so much for coming. Dr. Hussein Mohsen, who's a consultant, a pediatric pulmonologist at the Royal Hospital, Muscat, certificates in pediatrics and pulmonology from the Royal College of Physicians and Surgeons at Canada. He's the Associate Program Director, Pediatric Residency Program at Oman Medical, Senior Lecturer, College of Medicine and Health Sciences at Sultan Qaboos University. Welcome, Dr. Hussein. Thank you so much for joining us this evening. The young presenter presenter today is our very own senior resident within the Department of Pediatrics, who is joining respiratory in future, hopefully. He is Dr. Daryl Yo. He's in the part of the Department of Pediatrics at National University Hospital. With those words, I pass my stage on to Dr. Daryl to start the case presentation.
Hey, good evening, everyone. So I'll be starting my case presentation today. Thank you all for joining us today. So our patient, whose name is Adam, is a 5-month-old Malay boy with the main issue of recurrent wheezing, of which we'll be going through his timeline today. So more about Adam's background. Regarding his antenatal history, Adam is the third child of 3 children. Sorry, Dr. Mahesh, next slide. Born to non-consanguineous parents, and his antenatal scans were normal. Birth history-wise, he was born full-term at 38 plus 2 weeks via cesarean section due to previous maternal cesarean, with a birth weight of 2.93 kgs. His APGAR scores were 9 and 9 at 1 minute and 5 minutes respectively, and he had an unremarkable delivery and was discharged well at day 2 of life. His immunizations were up to date, and this included 2 doses of pneumococcal vaccines. Past medical history-wise, he only had eczema and was otherwise well. He had no previous admissions and is developmentally normal. With regards to his diet history, he was exclusively breastfed. He has not started weaning to solids, and there was no issues with feeding, with no reported or observed choking episodes during feeding. Next slide. So the following slide shows Adam's family tree. So his father and mother are 32 and 28 years old respectively and does office jobs. They are non-smokers. Adam has 2 older sisters aged 2 years old and 5 years old. And there's a strong family history of atopy in the family, with the father having asthma and allergic rhinitis, mother having asthma, his elder sister having asthma and allergic rhinitis, and a second sister with eczema. Adam also has eczema. Social history-wise, the family has a helper at home to care for the children. All 3 kids attend childcare. They have no pets at home and no financial concerns, and the child has insurance coverage. Next slide. So Adam presented to the emergency department at 5 months old on the 10th of May 2022 with 1-day history of fever, cough, shortness of breath, and wheeze. This was his first ever wheezing episode, and he had not fallen sick prior to this. His feeding was still intact, and his activity level was still good. It was noted that he had a strong family history of atopy, as detailed in the previous slide, with almost everyone in the family having some sort of atopy. So examination revealed an active and non-toxic child in respiratory distress. Vital signs were as such, with a temperature of 36.5, a pulse rate of 170 beats per minute, a respiratory rate of 52 breaths per minute, and saturations of 100% in room air. He had bilateral, subcostal, and intercostal retractions, as well as bilateral scattered crepitations and an expiratory wheeze heard across both lung fields with a tight air entry. Mild eczema was noted. Other systems were otherwise normal. Next slide, please. So Adam was treated symptomatically. He was given a trial of salbutamol pass via a metered dose inhaler with a mask and a space chamber. Adam showed response with improvement in the respiratory status after administration of salbutamol, with an improvement in its wheeze, air entry, and respiratory rate. He was then discharged from the emergency department with red flag advice and an outpatient follow-up. He did not attend this outpatient follow-up as the child was well. He was next seen at 1 year of age on 15th of November for his routine developmental assessment and vaccination. During then, the doctor found that he had normal lung examinations. Next slide. So Adam presented again to the emergency department on the 6th of February at 14 months old, this time with 3 days of fever, cough, and rhinorrhea, with 2 days history of shortness of breath and wheeze. He was more irritable than usual, with reduction in his oral intake by 50% and reduction in his urine output as well. On further history, he had a viral-induced wheeze at 13 months old in December 2022, where he responded to MDI salbutamol at home and did not seek any medical attention. He had otherwise no interval symptoms, and an examination at the emergency department showed a slightly tired, non-toxic child in respiratory distress. You can see his vitals here. He was febrile, he was tachycardic, a respiratory rate of 56 breaths per minute, and saturations of 92% on room air. There were subcostal and intercostal retractions with accessory muscle use, and auscultation of the lung revealed bilateral scattered crepitation and expiratory wheeze across both lung fields. There was also eczematous rash over all four flexors of his limbs, and other systems was normal. He was admitted to general ward for further management. Next slide. So Adam was admitted to the general ward and was reviewed multiple times and given several trials of salbutamol. There was transient improvement in his wheeze with the administration of this. However, overnight, his cough and work of breathing worsened with hypoxia, and saturations dipped to a lowest of 83%, requiring oxygen. There was also increasing respiratory distress, as you can see here on the right side here. So if you see the video, there's prominent subcostal intercostal retractions. He was very tired looking, and this was a video taken by his mother. Decision was made to send Adam to the high dependency for non-invasive ventilatory support. We can move on. So in the high dependency, Adam was initiated on CPAP plus 8. He was kept fasted and started on an intravenous drip. This is a short video taken by his mother. As you can see, he's very tired looking. So several investigations were done upon administration, which we'll go through in the next slide. Go through the next slide. So Adam's capillary blood gas showed a pH of 7.27 with a PCO2 of 44 millimeters mercury with a base excess of -6. A complete blood count showed a raised total whites of 15 with neutrophilic predominance of 74%. He had anemia with a hemoglobin of 9 with a low MCV, which was subsequently found to be due to iron deficiency anemia, likely dietary. His renal panel and electrolytes were normal, and there was raised inflammatory markers with a CRP of 96 and a procalcitonin of 1.7. Next slide, please. So this was his chest X-ray done in the high dependency. The next slide.
So this will be the first audience poll interaction. Give me 2 minutes, Daryl. Let's go through this poll. Where is the poll? Sorry. Okay, there we go. Can you all see the poll? I think so. Quite a few of you have started answering the poll. Okay, that's about 80% of you have already answered. So I'm going to end the poll here. And this is the result. So almost 60% of you have definitely given him humidified oxygen. About 50% of you would give him salbutamol. Adrenaline nebs, about 5% of you. And salbutamol with ipratropium neb, about 15% of you. So I think basically what you have all done is something that is a prevalent practice right across the region, across the world. And so if you look at the next slide, I've given you a QR code here. The QR code takes you to the most recent Lancet article in 2022, which talks about evidence-based management in acute bronchiolitis. And to my surprise, this particular article, if it had appeared in 1970s or 1980s, and it would have been exactly the same. Nothing has changed in bronchiolitis. Nothing works in bronchiolitis. It is only supportive care which is useful. Give him oxygen if the saturation is below 91%. No role for bronchodilators. Very limited role for adrenaline in a very severe child in the emergency room. No role for salbutamol or ipratropium or oral steroids or antibiotics. Hypertonic saline nebulization, there was a period for about 5 emergency. It reduces your stay in the hospital by 1 day, but that has not been proven very well with time. So I think essentially doing less is more in bronchiolitis. Let me now go to our first panelist, or rather, Daryl, it's you again. Sorry.
Yep. So I'll go through Adam's progress in the high dependency where he required a total of 10 days stay in the hospital. So within the first 24 hours, Adam required escalation of non-invasive ventilation from CPAP plus 8 to a BiPAP of max pressures of 14/6. He was also persistently febrile on day 5 of illness, and hence he was started on IV antibiotics, so IV ampicillin, and this was changed to oral augmentin subsequently, and a total of 10 days of antibiotics was given. Adam gradually showed improvement in his respiratory status and wheeze, and he was weaned off non-invasive ventilation after 6 days on the 12th of February. He became afebrile over the last few days of admission, with no further wheeze heard on auscultation, and only had scattered bilateral crepitations. So his total inpatient stay was 10 days, and he was discharged on the 15th of February. Upon discharge, Adam was also started on inhaled corticosteroids with Flixotide 100 mics twice a day. Next slide. So, sorry, previous slide. So of note, this time round, his respiratory virus culture panel actually grew parainfluenza type 3, enterovirus, rhinovirus, as well as adenovirus. So Adam represented again 1 week later to the emergency department. His mother mentioned that he had persistent symptoms of cough and intermittent difficulty of breathing and had given salbutamol as and when. His fever also recurred after 1 day of discharge after being afebrile for almost 4 days. As such, he had 1 week history of persistent cough, shortness of breath, and wheeze, as well as fever. Upon his representation this time round, he was febrile at 38 degrees, heart rate of 187, and a respiratory rate of 50. He required oxygen with 5 liters face mask. His eyes were still open, but overall slightly lethargic, with intermittent grunting and retractions. He also had a hyperinflated chest, and his lungs showed fair breath sounds bilaterally, with bilateral craps and wheeze, and a prolonged expiratory phase. His liver was torus, and his spleen was torus as well. Next slide. So these were Adam's investigations that were sent. His capillary blood glucose showed a pH of 7.43 with a partial pressure of carbon dioxide at 34.5 and a base excess of -1. His complete blood count showed a normal total whites of 9.7 with a neutrophilic predominance of 84%. His renal panel and electrolytes were normal, and the C-reactive protein done was not too remarkable at a level of 28. Next slide. So this was Adam's chest x-ray that was done. You can pause here for a bit. The next slide. Because of this, Adam was admitted to the high dependency for considerations again for non-invasive ventilation. During his high dependency stay, he was given salbutamol and ipratropium nebulization and only required oxygen supplementation. Non-invasive ventilation was not required. His respiratory multiplex became positive for enterovirus, rhinovirus, and adenovirus again. Adam was discharged after 6 days. Examination on discharge-wise, he had bilateral crepitations heard across both lung fields with minimal wheeze heard and no tachypnea. He was planned for an early review to our respiratory specialist clinic in 1 week. Next slide.
So that brings to the second poll for the audience as to what your working diagnosis will be. Let me give you the poll. Okay, so that's the poll. what will your working diagnosis be at this point? You think it's a transient early visa, a viral induced visa, a prolonged visa, multi-trigger visa, episodic visa, or an infantile asthma? I think there's one more, bronchial asthma there. This is, there is no one way of looking at this answer. So you can feel free, whatever you would do in your practice, you can write that. And it's totally anonymous. So none of us will know what you have answered anyway. So please feel free. I think about 60% of you have answered. I will just wait for another 10 seconds. Right? Okay, I'm going to stop the poll here. 220 of you have answered. I'm going to stop the poll and share the result. I hope you can all see the result here. Transient early visa, only 2%. For 50% think it is viral induced visa. 5% think it is prolonged visa. Multi-trigger visa, 13%. Episodic visa, 3%. Infantile asthma, 20%. And 9% think it is bronchial asthma. So you can see there is so much variability and there is so much confusion. And it's not confusion just here. It's confusion galore everywhere in the world. And to clear that confusion, I'm going to call on my first panelist, Professor Kabra, to share his thoughts on this. Professor Kabra, it's all yours.
Good evening, friends, and greetings from India. And in next few minutes, I'll discuss about what should be our approach to persistent or recurrent wheezing in preschool children. Next slide, please. So first and foremost is that it is being believed that majority of our children may have some noisy breathing or true wheezing below 5 years of age at some time or other. So our first aim should be to see that it is really a true wheezing or it is a mimicker. And there are multiple causes which may give rise to some noisy breathing, confusing us for wheezing. So first and foremost is recurrent viral infection associated wheeze, and it is with each acute respiratory infection. Then gastroesophageal reflux disease, which is feeding difficulty, lower respiratory tract infection or pneumonia. There may be disturbed sleep, poor response to treatment, and vomiting. If another cause in toddlers is foreign body aspiration, and there may be a definite history of choking, sudden onset of respiratory difficulty, and if you do auscultation, there may be asymmetric findings. Another common cause, which is emerging illness, is a protected bacterial bronchitis, in which there is a persistent wet cough of more than 4 weeks and poor response to treatment for asthma. Then another common, say, morbidity, which can be confused for a wheezing, is tracheomalacia, bronchomalacia, or laryngomalacia, and it is a persistent symptomatic since birth. There may be feeding difficulty, and there may be chest syndrome, and if it is a extrathoracic problem in form of a laryngomalacia, then it would be inspiratory sound. If it is in the inspiratory and expiratory, then it is in the major airways in the intrathoracic region. And if it is only in expiration, then it may be a bronchomalacia. TB in this part of the country is relatively common, and it may present with low-grade fever, contact with TB patient. There may be weight loss or no weight gain in last 3 months with localized wheezing if some lymph node is compressing on the airway. Cystic fibrosis, now in Asia, we are increasingly recognized, and child may present with persistent or respiratory recurrent problem with malabsorption. Primary ciliary dyskinesia is another emerging illness in the respirology, and there may be history of transient tachypnea of newborn at birth, followed by persistent wet cough, nasal ear discharge, and situs inversus in 50% of the patients. And other causes are bronchopulmonary dysplasia, compression of the airway due to vascular ring, immune deficiency, compression of the airway due to lymph node, tumor, or vessels, and post-infectious bronchiolitis obliterans. Next slide, please. And through wheezing, there are multiple phenotypes. And as you had already seen in the poll, that there are so many conditions. So all of them may not continue to wheeze in adult life. And there are two classifications, time trend-based classification, which includes transient wheezing in a preterm, early onset non-atopic wheeze, late onset atopic wheezing. Next. Or symptom-based classification in form of a episodic wheeze and multiple trigger wheeze. So this includes all the conditions which Dr. Mahesh has showed you. Nowadays, it is very difficult to differentiate or give a label. And that's how, if there is a recurrent wheezing, what should be your approach? I'll be discussing in next few slides. Next slide. So what should be my approach if a patient is having wheezing and child is happen to be young, below 5 years of age? First and foremost is confirm that it is wheeze only and it is not an atypical wheeze. The causes I have already discussed, and that may be evident from the history and some examinations. And investigations if required to rule out other causes, and treatment of episodic and long-term treatment. Next. So how we can confirm that it is really a wheezing? So we ask for some features which may suggest that it may not be wheezing or it may be mimicker, and that include that wheezing is persistent, something like a persistent from the beginning itself in form of a malasias, occurs during an inspiration and expiration both. Majority of our patients may have a expiratory wheeze only. And if it is a monophonic, if it is due to differential breath sound in different part of the chest, then it would be polyphonic wheeze, suggesting that it may be a small airway obstruction. But if it is a monophonic, it suggests that it is conducted from the major airways. It is not responding very well to the bronchodilator, not associated with other atopy. There is a significant history of failure to thrive, feeding problems, and extrapulmonary manifestations in form of say ear discharge, along with a gastrointestinal problem in form of a malabsorption. Next slide. And typical wheeze would be, it is waxing and waning course, polyphonic wheeze. It responds to inhaled bronchodilator. Most of the time expiratory, occasionally you may get an inspiratory and expiratory if there is a significant bronchospasm. Associated personal or family atopy, and there is a precipitating events in form of exertion, seasonal change, and during night. Next. So investigations, if required, to rule out other causes. I'll give you an outline that if it is an early onset, persistent wheezing, not responding to bronchodilator, there is a feeding problem, monophonic wheezing, or biphasic with no response to bronchodilator and failure to thrive, then it may be airway malacia, compression of the airways, and narrowing of the airways. And in those situations, you have to get an X-ray, and the first line investigation would be bronchoscopy because it is related to airway. CT scan if X-ray suggests possibility of space occupying lesion. Next slide. Then other is early onset persistent feeding problems. And there is a wheezing with choking, vomiting, aspiration, pooling of secretions, and failure to thrive. It may be aerodigestive problem due to malformations like tracheoesophageal fistula, laryngeal cleft, and other functional issues like gastroesophageal reflux or esophageal dysmotility. In those situations, the second investigation would be contrast studies to document if there is a malformation and, if required, swallowing dysfunction. Then subsequently, you can plan for a bronchoscopy and bronchial lavage for lipid-laden macrophage index. Next slide. If there is a wet cough, wheezing with crackles, and then you have to consider protected bacterial bronchitis, primary ciliary dyskinesia, cystic fibrosis, and in those situations for primary protected bacterial bronchitis, ball or sputum bacterial culture, X-ray, and primary ciliary dyskinesia, high-speed video microscopy, transmission electron microscopy, mutation studies, and nasal NO. And if it is suspected sweat chloride, cystic fibrosis, then sweat chloride and mutations. Next. Then we have covered the majority of the part, but occasionally you may find there are multiple infections. In that case, you have to do a primary immune deficiency workup. If there is a foreign body aspiration, history suggests, then go for a bronchoscopy. If it is a BPD by history, then X-ray and CT scan SOS. If it is intrathoracic space occupying lesion in form of a cyst, or it is because of the lymph node, then CT scan and MRI. And if it is a consistent with the post-infectious bronchiolitis obliterans, which Dr. Hussain will be talking to us, then you have to go for a CT scan, broncholar lavage, and if you are suspecting it to be TB, then gastric aspirate, broncholar lavage, or IBUS, etc. may be carried out. Next slide. So, a treatment would be to treat an underlying cause if identified for all atypical wheezing. If underlying disorder is not present, then it is a typical wheezing, and treatment of individual episode for all with, as Dr. Mahesh said, as in form of a bronchodilator and if indicated steroids, and continuous therapy to be individualized. Next slide. So any child who is presenting with wheezing below 5 years of age, in that case, you will take a history of atopy, asthma. If it is, and then you'll ask for a frequency of wheezing. Next, if it is infrequent, like once in 2-3 months, no regular prophylaxis is required, and you treat episode symptomatically with salbutamol. And if it is a frequent, that is defined as more than 3 episodes in a year, and or severe episode, or even in the one season there are more than 3 episodes, consider regular inhaled corticosteroids or leukotriene antagonist, and preemptive LTRA or ICS4 is not recommended routinely. And once you have started on inhaled steroid, you'll assess the child after 4 to 8 weeks. If there is no improvement, stop medication, reaffirm the diagnosis, and try the alternative drug. If next, if there is a benefit at 12 weeks, asymptomatic, recommendation are that you can stop and follow it up. If there is a recurrence, then you will treat asthma. It's asthma. So here it is very clear that you are now those recurrent episodic wheezing, multi-trigger wheeze, transient episodic wheeze, all those have been obsolete, and you will see more of a frequency and severity of wheezing and decide about inhaled steroids. So in our index case, Adam, child has a persistent wheeze, some response to bronchodilator, personal family issue or atopy. Unusual features are repeated hospitalization, failure to thrive, poor response to treatment for recurrent wheeze, and there is a longer virus shedding. In that situation, you need to investigate the child by a bronchoscopy and bronchial lavage and possibly CT scan of the chest. Next.
Thank you, Professor Kabra. Thank you so much. I can now hand over the mic to Daryl to take us through what happened with this kid later. Daryl?
Thank you, Professor Cabra. So 1 week after discharge, Adam was seen in our outpatient respiratory clinic. He was noted to have 1-day history of cough, increased work of breathing. On examination, his respiratory rate was 50 and saturations were 94% with bilateral craps and a mild wheeze. He was, however, clinically well, and thus decision was made to monitor him closely. However, we also note that charting of his growth parameters actually showed a tailing growth with a drop in his weight by 2 centiles from 44 to 12 centile. His parents were then counseled for the need for further evaluation in the form of bronchoscopy and CT imaging when he was well, as what Professor Cabra has mentioned. So the next slide actually shows Adam's growth chart, which shows a drop of 2 centiles when his weight was plotted from the 44th to the 31st to the 12th centile. There was initially a bit of reluctance in terms of the bronchoscopy as well as the CT thorax, because the parents were saying that he was clinically quite well at home, he was still quite playful, still quite happy. But his growth has definitely taken a hit for the worse, and he also had frequent episodes of wheezing. So Adam was then electively admitted for further investigations. A bronchoscopy was done with a bronchoalveolar lavage, and this showed a normal anatomy. The bronchoalveolar lavage results was positive for Streptococcus pyogenes, and the TB, Aspergillus, and fungal cultures were negative. Lipid-laden macrophage index was normal as well. Several blood tests was done as well, including immunoglobulins and lymphocyte subsets, of which were normal. We go on to the next slide. So these are some cuts of the CT thorax done. In
Thanks,
the
Doug.
following slide,
Take it
yep.
here. So basically, this is the CT cuts. You can see the coronal as well as the axial cuts. And I will show you a video on both views as well. This is the axial view of the CT, running you through the entire CT of the chest. Can you all see it?
Yep, now we can see it.
Okay. So that is, I'm having some problems with my computer here. I'm sorry. So that is, okay. Okay, so we come to the next audience poll. Here, I want you to tell me the diagnosis based just on the CT scan. So just for a minute, don't tell me about what you thought about the clinical situation. I'm asking you purely on the CT scan. So there we should see your poll launched. I hope you can see the poll. What's the most likely diagnosis based on the CT scan? Pulmonary tuberculosis, pulmonary alveolar proteinosis, neuroendocrine cell hyperplasia, bronchiolitis obliterans, pulmonary interstitial glycogenosis, PIG, pulmonary aspergillosis. When I was doing this slide, just while you are answering, it was so interesting. We have got used to mnemonic so much. The first one is TB. The second one is PAP. The third one is NEHI. The fourth one is BO. The fifth is PIG. Except pulmonary aspergillosis, I am not aware of any mnemonic just for that. Of course, ABPA becomes a different thing, but pulmonary aspergillosis, I don't have an answer. I think I will have about 50% answer. I'll give you another 10 seconds. Once it hits 200, I'll probably save time for discussion later. Okay, I'm going to stop the poll here. I'm going to share the result with all of you. As you can see, about 70% of you think it is BO, bronchiolitis obliterans, and 11% TB, 9% PAP, and aspergillosis only 4%. Okay, so I think that is what the poll said. Now let us see where we go with this particular patient next. And here I think I'm going to, 1 minute. Now I'm getting my second panelist for you, Dr. Hussein from Oman. Dr. Hussein, it's all yours.
Thank you, Dr. Mahesh. I would like to start by thanking the APPS for inviting me to participate today. So as most of you have voted, it seems that post-infectious bronchiolitis obliterans is the likely diagnosis in this patient. This is, as most of you know, it's a wide topic and it's difficult to summarize it in 10 minutes. But I will just go through some key important points that all of us should be keeping in mind when dealing with this clinical entity. Next slide, please. So as you all know, so bronchiolitis obliterans is rare, and it's a chronic form of obstructive lung disease. BO can follow infection, and it's called post-infectious BO. It can also more commonly follow bone marrow transplantation and lung transplantation. So both the two entities of post-BMT and post-lung transplantation has been well studied with a good amount of evidence-based practice, while in post-infectious BO, it's actually not that much studies. The prevalence is not that known. Like in BMT and post-BMT, we know it's around 2 to 6%, and in post-lung transplantation is around 35%. But the exact incidence and prevalence of post-infectious bronchitis obliterans is not well known. There is a fact that it seems that it's more common among certain population, like the Argentinians, naive Americans, and naive Koreans. That would suggest a genetic predisposition, which is still yet to be identified. It was clear while preparing for this talk that most of the studies are coming actually from South America and from Asia. In terms of the long-term outcome, so it's variable. So people estimate 20% to progress to end-stage lung disease, while 20% make a full recovery, and the other 60 will be something in between. Next slide, please. So when we talk about histopathology or the pathophysiology of post-infectious bronchitis obliterans, so it's a form of constrictive bronchiolitis that is typically affecting the bronchioles and the conducting respiratory zone. So it's not usual for this to involve the alveolar duct and the alveoli. Usually it starts with an epithelial injury that's induced by some sort of infection or irritant. This follows release of interleukin-8 and pro-inflammatory mediators, which actually recruit neutrophils and other inflammatory cells into the small airways. After that, the matrix metalloproteinase and fibroprotic cytokines are released. This really results in matrix degradation and collagen disposition, fibroblast proliferation, and eventually the fibrosis, subepithelial fibrosis. It's also important to keep in mind that there is increase in IL-17 and IL-8, which actually attracts neutrophils. So usually the inflammation in BO is with neutrophils, and that's important to keep in mind when we will be discussing the therapeutic options later on. Next slide, please. So this is actually a very nice table that summarizes the different insults to the airway that may trigger the cascade of inflammation that we talked about in the previous slide. So it ranges from infections, so adenovirus being the most common, specifically serotype 3, 7, and 21. Influenza, parainfluenza, measles, RSV, mycoplasma, and pertussis, all of them has been actually also reported to cause bronchiolitis obliterans. Inhalation injury, aspiration of lipids or gastric fluid can actually sometimes induce bronchitis obliterans. Immune dysfunction, which is the physiology in post lung transplant and in post BMT. Also, bronchitis obliterans can actually be a complication of Stevens-Johnson syndrome. So we'll move to the next slide. So diagnosis of bronchiolitis, post-infectious bronchitis obliterans requires actually a high index of suspicion. So as Dr. Cabra described earlier, approach to recurrent wheezing is extremely important. We have to keep in mind unusual, atypical presentations in order to catch these patients earlier. So it's very well documented in the literature that there is an issue with late diagnosis of post-infectious bronchiolitis obliterans, with the time from onset of symptoms to diagnosis being from 15 months to around 87 months in the literature. This, of course, means that we will be catching these patients at a later stage where fibrosis is already there. And that's basically a late diagnosis. If we look at this table, so this table actually summarizes what I would like to call the triad of BO. So the triad consists of a history of a prior insult. This insult, as we described earlier, could be infectious or others, plus The second aspect of this triad is the clinical or PFT evidence of a fixed airway obstruction. And the third aspect of the triad is the typical CD findings, as we will be describing in the next few slides. So if you have that triad, think about post-infectious BO. Next. So Colom and his colleagues back in 2009 described this predictive score, that actually gives points to each of the three aspects that we talked about: typical clinical record, adenovirus history, and mosaic pattern on CT. And if you have a score that's more than 7, it's highly predictive of a diagnosis of PIBO. Next slide. So HRCT is the most sensitive radiological investigation to diagnose PIBO. It's extremely important to keep in mind the clinical background. I have personally received multiple referrals from some of the colleagues from general pediatrics with a radiological diagnosis of BO because the CT was done during an acute asthma exacerbation. So during asthma exacerbation, if you have wheezing, if you have air trapping, you will end up seeing the same CT finding. So it has to be interpreted within the clinical context. So there was a very nice study done by Fisher and his colleagues that reviewed 250 children in South America. They reported that 88% of children with BO had mosaic perfusion, 92 had air trapping, 78% had bronchial wall thickening, and around 96% bronchiectasis, and there was evidence of mucus plugging as well. Ideally, both inspiratory and expiratory images should be obtained, as you can see in this picture. During expiration, the image almost looked normal, apart from increased radio opacity that would, or decreased attenuation that points towards air trapping, but the mosaic pattern was more visible on the expiratory phase. So this is not easy in small children, as you know, because that may require sedation or may require general anesthesia. So in this case, one of the alternative approaches described in the literature is that you do the cubitus fill, and the dependent lung will work as your expiratory lung. Next slide. In terms of other workup, so it's generally accepted that bronchoscopy and bronchoalveolar lavage should be done to rule out other etiologies, especially infections. PFT, the problem with this is that it's very useful if it can be obtained, but most of children affected with BO are less than 3 years of age. So infant PFT is not widely available. In terms of lung biopsy, so histopathological confirmation is the gold standard, but keeping in mind that the disease is actually patchy, and obtaining an open or thoracoscopic lung biopsy carries comorbidities by itself or morbidity by itself. So it's generally acceptable that BO can be diagnosed based on clinical radiological features and the prior history, as we mentioned earlier. I already touched on the importance of early diagnosis. Can we move to the next slide, please? So there is multiple studies attempt to look at risk factors for developing post-infectious bronchitis obliterans. So this is a study was done by Dilu and his colleagues from China. It's a systematic review and meta-analysis of multiple studies in 2022. And basically, they studied 14 risk factors that was obtained from 9 studies. As the table would show, Dr. Mesh, if you can click on the factors. So being male carries a risk factor. Next is actually the history of wheezing, followed by the clinical manifestation of wheezing, tachypnea, and hypoxemia. The co-infection with a bacteria, and if the patient received mechanical ventilation, steroid, or alpha globulin, all of these are described risk factors. There is also a work on the genetic predisposition. So there is a study that showed in these patients, there is increased frequency of polymorphism in the mannose-binding lactin, which suggests a role in this subset of children. Next slide, please. So moving to treatment. So treatment is mostly, there is no acceptable protocol. It's mostly expert opinion and extrapolation from post-BMT and post-transplant literature. This table, which was obtained from the post-infectious BO diagnostic workup and therapeutic workshop report, that actually focuses that the treatment should target anti-inflammatory. And in addition, we have to keep in mind the supportive care, which includes oxygen supplementation, nutrition, vaccination, avoidance of irritants, airway clearance, and pulmonary rehabilitation. So all of these aspects are very important. There was a study looked at sleep disordered breathing in children with PIBO, and they clearly showed that these children have nocturnal hypoxia or hypoxemia, and that's actually correlates with the severity of lung disease measured by Infan PFT. Next slide. So in terms of the available study for post-infectious BO, so these are three important studies. They use different cocktail of medications, so including oral prednisolone and azithromycin, and the outcome is that generally there is benefit in these children. However, given the side effects associated with prolonged use of oral steroid, most people would actually treat with pulse steroid. Can you move to the next slide, please? So it's generally, and it's a common practice that people treat post-infectious BO with IV methylprednisolone pulses ranging from 10 to 30 mg per kg, giving over 3 consecutive days for around 3 to 6 months. Tomikawa and his colleagues studied 40 children with PIBO that all of them received methylprednisolone pulses, with a group receiving inhaled corticosteroid. And they had shown that it was associated with decreased frequency of wheezing and hospitalization, increase in oxygen saturation, improvement in growth, decreased use of supplemental oxygen, and the ability to wean them from daily oral steroid. Next slide. So other modalities. So there is, for IVIG, there is no clear RCT, but there is an anecdotal success reported in the literature of using IVIG. Now, is the rule, is it through immune modulation or through prevention of infection? It works, that's not clear. The typical dose is 1 gram per kg per day for 2 days monthly over 3 to 6 months. In terms of other medications, so if we talk about azithromycin, so there is again no RCT for PIBO that used azithromycin. However, these studies, it has been successful in children post BMT. The rationale or the pathophysiology is because it targets IL-8 and the neutrophilic inflammation. So usually it's a common practice to use azithromycin 10 mg per kg given 3 times per week in these children. Again, it's all extrapolation from other practice. The other, can go to the same slide. So the other approach is the FAM, which is it's a common practice of using azithromycin, steroid, and montelukast. And again, it has not been studied in PIBO, but reported in small case series with some benefit. In terms of bronchodilators, so theoretically it's a fixed obstruction, but actually response to bronchodilators has been reported as high as in 40% of PIBO. So it can be used on an individual basis. For tiotropium, there was a recent study that showed good response in children using PFT. That study did not talk about any clinical benefit, but they measured serial PFTs over 24 hours, and every time these children had improvement in their FEV1 using tiotropium. From a personal experience, I have used it on a patient with PIBO, and we have noticed reduced wheezing and improvement in his exacerbations. Other mechanisms that has been described in the literature, including extracorporeal photopheresis, tumor necrosis factors, and anti-IL-6 therapies, that also based on individual practice and has not been widely studied. So I'll end here, and later on we can discuss further in the questions.
Thank you so much, Dr. Hussain, for compressing a huge topic into 8 or 9 minutes. We will now go to an audience poll. Now you have seen what PIBO looks like and how you need to treat it. I would like to ask the audience, how many of you have actually encountered PIBO in your practice? This is just a very academic kind of question, because we would like to know what is the incidence in various parts of the Asian region. I'll wait for about 200 plus. I think I've got about 150, so please carry on. We just want to know your practice and how much you have been exposed to PIBO. Okay, 5 more. I think I'll end it here, 195, but for lack of time, interest of time, I'm going to end the poll here. And I'm going to share 205 of you. So 31% say 0. So about a third of us are not exposed. About 35% say 1 to 2. That is very, very typical. There is all centers have a few experiences, but not huge. I can see about 10% of you have seen more than 10. Wow. So this is an opportunity for all of you to kind of get together and start having some Asian network to show what a BO in Asia looks like, because there is still lack of literature in that. So I would recommend all of you to come together and share some literature or publish something from the Asian side. So let me go over to Daryl for the last couple of slides. Daryl, over to you.
Okay, thank you very much, Dr. Hussain and Dr. Mahesh. So, like we mentioned, so Adam was thus diagnosed with post-infective bronchiolitis obliterans, and counseling was done with his parents with regards to this new diagnosis. He was started on FAM therapy, which consists of flixotide 2 puffs 2 times a day, azithromycin, as well as montelukast. He was also counseled on parents were also counseled on the importance of influenza vaccinations, and he was also referred to our immunologist for further immunological workup. In view of concerns of increased work of breathing and several wheeze exacerbations due to various upper respiratory tract and lower respiratory tract infections, requiring at least about 3 or 4 admissions over a span of a few months, decision was made to give Adam monthly IV methylprednisolone 10 mg per kg per day every time for 6 doses, and so far 6 doses have been given from October to March 2023. Sorry, this should be March 2024. So after these doses of IV methylpred, Adam has responded quite well. He's actually currently overseas right now, and this has actually reduced his number of exacerbations thus far. Thank you very much. So this is his current growth. So at roughly about 20 months of age, you can see a slight dip right in the middle, and then subsequently, with improved nutrition, with the dietitian on board, his growth has slowly picked up as well. Of course, we are also monitoring for side effects of the steroids, of which thankfully he has none. Thank you.
Thanks, Daryl. Thank you so much for that wonderful presentation. Thank you really so much for preparing hard and doing that. I think we have some questions. I will have my colleague, Dr. Michael Lim, present the questions to the panelists. Dr. Michael, have you categorized them to the panelists?
Yeah, I have. Hi.
Hi.
Okay, quite a lot of questions actually. So we've answered a few of them on the Q&A itself, but there are a few more. So I think maybe sort of Daryl, there's just one comment apart from what you said. The patient had rhinorrhea and atopy. So was the patient managed for atopic features?
Yeah, so the patient's rhinorrhea was actually only during his acute episodes. I mean, there was no actual suggestion of moderate or persistent allergic rhinitis. So he was just basically given cetirizine, some oxymetazoline nose drops during his acute exacerbations. With regards to his eczema, he was actually treated with moisturizers as well as topical steroids such as desonide. He was also referred to the allergist who has been on follow-up with him since.
Okay, thank you so much. We had a couple of questions when Prof. Cabra was talking, so perhaps I'll pitch them to Prof. Cabra. Anonymous question, what's the difference between viral wheezes and episodic wheezes?
Yeah, these are one or the same thing, and there are multiple terminologies. And as I made it very clear that nowadays these are no more being used or obsolete. We just see the frequency of wheezing episodes and then severity of wheezing episodes. We give them inhaled steroids. Now this episodic wheezing, multi-trigger wheezing, viral infection associated wheezing are no more being used. If it is more than 3 episodes, we in a year, severe episodes, we give them a trial of inhaled steroids, see if they respond very well. If there are no other reasons to suspect asthma, we'll stop it and follow it up. If there are reasons for asthma, then we'll follow them as a asthma.
Thank you. Another question, I think from Priya Garohi, what is mimicking wheeze? I think you made a comment about mimicking wheeze, looking for differential diagnosis, because wheeze is a clinical finding. That's perhaps a clarification.
Yes, it is important that any abnormal sound from the respiratory tract for a parent is a wheezing. And they may come with the history that my child wheezes a lot. But it is for the physician, for a respirologist to decide, is it only in expiration, as I had written very clearly, typical wheezers. It means it is waxing and waning, recovers and then recurs again. So if it is persistently wheezing, no response to bronchodilator, it is inspiratory and expiratory, then it is more likely to be mimicker rather than a true wheezer.
Thank you. Okay, for Dr. Hussein Mohsin, there were quite a few questions during your section, but Prof. Cabra, feel free to chip in also. I think Dr. Sakshi asked, mean age for diagnosis of PIBO?
Dr. Hussein?
Yeah, so the exact figure, I don't recall the exact figure, but mostly it's below 3 years of age. But what's important is actually from the time of onset of symptoms until diagnosis. So what's reported in the literature, it can reach 1 year to even 2 years until someone would actually think about BO, post-infectious BO. And that's what we need to change after this talk.
And Dr. Mola asks if we can see the classical mosaic CT findings of BO, or what clinical clues will compel us to suspect BO. I think you've covered that in your talk.
Right. What I was trying to highlight is that it's not only the CT, it's the CT in addition to a history of a prior insult being a viral infection like adenovirus, but other viruses like influenza and RSV, plus the clinical history, which is very similar to Adam. So recurrent or persistent wheezing after that specific episode. And you put this in addition to the CT, and to make sure that CT is not done while the child is acutely sick, as much as possible to be done when he is relatively stable. That would actually help in putting things together and make the diagnosis.
One last question, Michael. In the interest of
One
time.
last question. Okay, in the interest of time, I think there are a lot of questions about treatment really on FEM therapy and steroids. So I think take your pick. I think the question is sort of, pulse methylprednisolone versus oral prednisolone and inhaled steroids. Any particular preference, because there's so many varied regimes out there.
Sure. So I think one of the questions is there any head-to-head study comparing methylprednisolone pulses to oral steroid? I did not come across any of such a study. Some people would use oral steroid, some would use methylprednisolone pulses. Both report success, but probably thinking about side effects, methylprednisolone pulses seems to be a better approach. Now, this is between the doses, the patient would be on some supportive therapy, and that would include, so FAM is basically, it stands for fluticasone, for F, azithromycin for A, and Montelukast for M. So this is what's being studied in the post-BMT literature and has been shown to reduce pulmonary exacerbations and improve in symptoms. So many centers would actually continue at least the inhaled steroid and the azithromycin in between these two episodes, in addition to what we have described earlier, good nutrition, oxygen supplementation if needed. There's
Thank
actually
you.
an interesting study.
Thank you, Dr. Hussain. Thank you so much. I think it's almost 8, 9, 8, 9, 8, 8, and 8:10. So I think we need to probably stop. Just to summarize in 2 sentences, would be acute bronchiolitis. There is still so much confusion and so much being done. But I think the message today was less is more in bronchiolitis. So the less you do, the better for these children. So don't be too aggressive in acute bronchiolitis. When you have a child with prolonged wheeze, persistent wheeze like what we had, always keep your options open. Don't think of just bronchiolitis. It might be many other diagnoses, as has been discussed. PIBO is certainly one of the differential which you need to worry about. Aggressive, if you think of PIBO and if you prove it, then aggressive early treatment can thwart the progress, and that is important for children with PIBO. I really thank my co-panelists, but I would hand over my stage to Dr. Ann Go, Professor Ann Go from Singapore.
Right, thank you, Mahesh. And I'd really like to thank the Singapore team for putting such an interesting case together. Dr. Daryl for presenting and Dr. Mahesh for moderating this session, and the 2 excellent panelists, Professor Kabra as well as Dr. Hussain from Oman. Just to remind you that our next grand round will not be in a month's time. It will be in 2 months' time. It will be in July. Okay, so it will be at the end of July, on the 26th of July. So keep that date free. And again, keep the dates at the end of this in December free as well for the APPS annual congress, which will be held in Oman as well. So I think it's going to be an exciting congress, and our next grand round will be hosted by our colleagues in Oman as well. So do keep that date free, 26th July. Okay, so it really leaves me to thank all the panelists as well as the host, Dr. Mahesh, as well as Dr. Daryl for putting together such an excellent presentation. Thank you.
Sorry, that is my apologies. While you were talking, I couldn't get the slide on. So you can see the poster for the next case presentation. Forget about my personal things on the left side. So hopefully, yes. There we go with the AVPS poster for the next round. It's on 26th of July. If you like this and if you want to join us for more of these, so it is.
Yes. Yes, so keep that date free, 26th of July, right?
Thank you.
Okay.
Thank you so much. Thank you.
Thanks.
Thank you. Thanks, everyone.